So good morning, everyone. We just had the first session of the 15th International Workshop on Non-Hodgkin Lymphoma. That session was devoted to T-cell lymphomas and more specifically developments with respect to targeted therapies. So the session was co-chaired with Dr. D'Amore from Denmark, and we had 4 successive talks that were preliminary to a general discussion. 2 of the talks were devoted to the biology of those lymphomas, a summary of the developments in the knowledge of the pathways that are deregulated in those malignancies was presented by Dr. Philippe Gaulard from Créteil. That was followed by a talk by Dr. Ingirami from New York, who presented about the development of patient-derived xenografts for modelization of lymphomas. So after that first part, we went on to the clinical talks. The first one was given by Dr. Delarue from Hôpital Necker, and he talked about the various ways of considering targeted therapies for T-cell lymphomas and how to see and how to organize clinical trials in that clinical setting. And finally, Dr. D'Amore talked about the recent developments in T-cell lymphomas. That was followed by an animated discussions with many of the participants, many questions still unresolved, but some interesting openings for developments. Dr. Gaulard, you presented us a nice overview of the recent developments in understanding the pathology and the molecular pathology of those diseases. Would you like to summarize the main pathways that?
Yeah, the T-cell lymphoma, the peripheral T-cell lymphoma, are a complex group of heterogeneous diseases, but I try to summarize how, based on the recent discoveries and gene expression profiling and almost next generation sequencing, we now have a kind of landscape for each of these disease entities that can be grouped in different pathways. So generally speaking, it seems that to have normal T cells transform into a lymphoma, you need an association of alteration that will most often target epigenetics modifier. You will have accumulation of alteration in the different signalings, and especially the TCR signalings and the JAK-STAT signalings are very important in T-cell lymphoma. And you will need also, of course, to have other things, and especially dysregulation in cell cycle or apoptosis. Of course, this is not all. You can have things, you should take care of the environment. But based on this, we know now that the landscape is more or less specific for some T-cell lymphoma entities. For example, the most prevalent entity derived from TFH cells, the follicular helper T cells, which give rise to angioimmunoblastic T-cell lymphoma and other group of PTCL. They are characterized by mutations in TET2 or DNMT3 or IDH2 as epigenetic modifiers that give rise to hypermethylation and accumulations of mutations in the TCR signalings. And of course, one of the main issue of my presentation was to show how now we have some targets that could be actionable to improve the outcome and the prognosis of those patients, which currently is still poor. Of course, we don't know everything. We need, of course, to understand better the integration of these biological pathways in each disease, and probably the mice models of PDX xenograft mice could be very interesting in that way. And also, I think, and this is a question for our clinician, we need to know now the next step, how we are going to introduce and integrate this data into the clinical setting.
There was also an interesting aspect in your presentation. You nicely correlated the type of pathways that are affected with respect to the type of lymphoma. Would you like maybe to expand a little bit on that?
Yeah, for sure. There is that's general overview I mentioned, but of course there are specific pathways or specific genes in single pathway that are involved in specific disease entity. If we, for example, deal with the signaling, which can be actionable by different compounds, it appears that most of the T-cell lymphoma probably derived from cells of the adaptive immune systems are characterized by TCR activation due to mutations in the TCR gene cascade. Whereas, for example, those lymphoma, which are mainly extranodal, mostly aggressive, derived from cells of the innate immune system, they do not have, so far, or rarely have, mutations in the gene of the TCR cascade, but they will have more activating mutations in the JAK-STAT pathway. So it's very interesting to see how it balances, between these two categories of T-cell lymphoma. And probably that could have implication for therapy.
Okay, so Francesco, maybe you want to give us an insight into the current lines of therapies, the situation, the challenges, and we'll ask Dr. Delarue afterwards to comment on the future developments related to specific alterations in targeted therapies.
Yes, in terms of the present landscape, I tried to summarize what we have learned so far with the large clinical trials that we've run during the last decade. So what is the clinical experience basically that we have, regardless of whether we believe more in one or the other upfront strategy. They probably look in a way similar altogether, because attempts to change on what we today have as a standard induction treatment has so far not been successful. So I tried to show these attempts in different trials that try to substitute the CHOP chemotherapy or the addition of a etoposide to CHOP, but trials that have investigated other combinations of conventional chemotherapy have not shown superior results. So basically it was the pattern that we in the Nordic group that I represent here at this meeting have experienced, is that we have a third of the patients that are very early on refractory to treatment and progress. So this experience may also vary a little bit. I present the data of the Nordic experience, which is about 30-35%. And then there is another group of patients that are initially chemosensitive, but after end of induction and consolidation, if you are one of the centers that do high-dose therapy, for example, then there will be 20% of patients that relapse within the first 2 years. Also, if you are able to follow your patients long enough, you will realize in a sufficiently large cohort of patients that there will be some that experience a late relapse, which is after 5 years. We have seen patients relapsing with an anaplastic large cell lymphoma with the same clone 7 years after end of treatment. But these are of course not the majority, but still if you also are able to take care of that, you will be able to end up with a better figure of outcome for PTCL altogether. So this was a kind of summary of where we stand with the current approaches, and the importance, with some examples, to join or to connect, to link the wealth of new biological information to to this platform. I think that doing that, it will allow us to discern between some short-lived pseudo-success stories that in the beginning look good but then fade away, as we've seen for some compounds and drugs. And anchored in this platform and landscape, we will be able to see the real game changers.
Thank you. So, as you mentioned, we have serious challenges with treating those patients, and maybe I'd like to ask Dr. Delarue to summarize here his talk. You made a nice presentation of the novel opportunities and how you would see to apply that concept of personalized medicine to the service of treatment of these patients.
Yes, the first point is that the prognosis of patients with relapse and refractory peripheral T-cell lymphoma is very poor. With classical chemotherapies, the response rate is no more than 30%, and the median overall survival of this population is no more than 6 months, even worse for patients who relapse within the 2 years. There are several single agents currently approved in the US, such as pralatrexate and HDAC inhibitors, but without clear improvement compared to classical chemotherapies, even if there are several patients with prolonged response under this treatment. Regarding the targeted therapy, there are at least 2 successes in peripheral T-cell lymphoma. The first one is crizotinib and ALK inhibitors in ALK-positive anaplastic large cell lymphoma, with a clear efficacy of those compounds.
This was really remarkable.
Yes, because all patients initially respond to the treatment, and a high proportion of patients are still in CR even outside of consolidation therapy with autologous or allogeneic stem cell transplantations. The second success is pertuzumab vedotin in the setting of systemic anaplastic large cell lymphoma, ALK positive or ALK negative, with an approval in the US and in Europe in this indication, with several significant proportion of patients who are free of therapy and still in CR after more than 5 years after therapy. It has been demonstrated by a recent presentation during ASH meeting. Beside of these 2 therapy, there are many other options for us today based on the biology of those diseases. There are options in new monoclonal antibodies with new targets such as KIR3DL2, such as CD30 outside of anaplastic large cell lymphoma, and maybe other. There are opportunity in kinases inhibitors, because a lot of kinases are activated in peripheral T-cell lymphoma, such as PTGFR or VEV1 recently in Henri-Mondor T-cell lymphoma. It's probably the target of the ROAJ17V mutation. Checkpoint inhibitors, obviously, it could be an option in several subtype of T-cell lymphoma, such as ABV positive and most importantly NK disease. JAK-STAT inhibitor, and I have remind to the audience our publication, our presentation with 5-azacitidine, because there are a lot of deregulation of DNA methylation in Henri-Mondor T-cell lymphoma, and we try to treat patients with 5-azacitidine, and we reported a significant response rate, significant PFS for those patients. Several patients are under therapy more than 5 years after diagnosis, and several patients are off therapy and still in CR.
That was as a single agent?
It was as a single agent, and we are currently thinking about a clinical trial, a phase 3 trial against standard therapy for those patients with Henri-Mondor T-cell lymphoma or TFH-like PTCL loss.
That sounds definitely like a good application of the concept of personalized therapy, but I was also a bit puzzled by the fact that I think you showed a lack of response to imatinib in a series of patients who apparently were supposed to have or had evidence of PDGFR alpha activation. So
yes, there's a gap between the biology and the clinics sometimes, but I think we will find some targeted therapy in the next future for those patients.
So you suggested to have patients being screened molecularly at the diagnosis or early relapse to potentially identify targets. I think you mentioned the problem might be no targets in some patients, but how would you handle when you have two targets or more?
I think it should be mandatory today for all patients with peripheral T-cell lymphoma, given the bad prognosis of those patients and the lack of standard therapy for patients who relapse or who are refractory. It's mandatory to think about a precise molecular profile and a pathological review of all patients at diagnosis to be sure that at the time of the relapse or when those patients are refractory, we can think about a targeted therapy for those patients. It's quite difficult. There are many pitfalls from the time of diagnosis, the quality of the samples, the bioinformatics, the quality of the molecular analysis, the drug supplies, how to translate into clinics. But I think it's mandatory because of the bad prognosis of those patients.